Hello, my name is Marvella Garcia, and I will be presenting case study number 4, Bulimia nervosa. The patient is a 42-year-old married male who is presenting to an eating disorder clinic. Over the past 5 months, he has lost a total of 58 pounds. Even with this weight loss, the patient is reporting that he is terrified of getting fat. He reports that in the past, he was always somewhat heavy and a stress eater, but he had never worried about his weight. 5 months ago, his wife criticized his weight and appearance, calling him a fat slob, and the fear of a possible divorce initiated the patient to then embark on a very strict diet. His original goal was to lose 50 pounds. When the patient felt that he was not losing weight fast enough, he then began to initiate the inappropriate compensatory behavior of inducing vomiting by sticking his finger down his throat. The patient reports he feels he is now obsessed with food. Whenever he is going to go out to eat at a restaurant, he worries about what he will order. He is very knowledgeable about where every bathroom is located in areas that he frequents, and he has now learned which foods are easiest for him to purge. 3 to 4 times a week, the patient is unable to resist the urge to binge, and he feels out of control during these episodes, and he eats large amounts of foods in one sitting. In one sitting, he can eat 3 hamburgers, 2 orders of French fries, a pint of ice cream, and 2 packages of Oreo cookies. The patient then induces vomiting after every single binge episode. The patient currently denies any use of diuretics, laxatives, or pills to help with weight loss at this time. He also reports that he cannot bear feeling full, and he has a current preoccupation with being thin. He continues to make changes to his original goal weight downwards. So originally he had a goal weight of 190 pounds, and he has now changed that to 185 pounds. He has also now initiated a rigorous daily exercise program to prevent weight gain. He is walking about an hour a day, and he has also started weightlifting several times a week. The patient is reporting that he feels like he can no longer regularly enjoy meals. He reports feeling out of control with regards to food and this area of his life, as he cannot stop the dieting, the binge purge episodes, or the exercising to prevent and stop weight gain. The correct diagnosis for this patient using DSM-5 criteria would be bulimia nervosa. Some differentials to consider for this patient would include anorexia nervosa, which is ruled out due to the patient not being significantly underweight. In fact, his BMI is 25.3, which puts him in the overweight category by about 2.5 pounds. Another differential to consider would be binge eating disorder, which was ruled out due to the fact that the patient is participating regularly in inappropriate compensatory behaviors. The rationale for the diagnosis of bulimia nervosa using DSM-5 criteria is based upon the symptoms the patient is exhibiting, which include recurrent episodes of 3 to 4 times a week of binge eating in which he feels out of control, engaging in inappropriate compensatory behaviors such as inducing vomiting or purging after every single binge eating episode, and engaging in excessive amounts of exercise to prevent any weight gain from the amount of food that he consumes during the binge episodes to prevent weight gain and to continue to lose more weight. And also the self-evaluation that the patient engages in by being preoccupied with his body shape, by thinking his stomach looks fat, placing emphasis on being thin, and the increasing need to lose even more weight due to the significant fear of gaining any weight at all. All of these symptoms have been present for at least 3 months. The evidence-based treatment plan for this patient would include cognitive behavioral therapy, specific for eating disorders, as the first-line treatment. Many studies have indicated the effectiveness of cognitive behavioral therapy for the treatment of bulimia nervosa. A meta-analysis study that evaluated 21 randomized controlled trials showed that not only was it the most effective a treatment, but patients were able to achieve full remission by the end of treatment. The cognitive behavioral therapy treatment for this patient would consist of about 20 sessions over a period of 5 to 6 months, with ongoing evaluation to assess whether more sessions are needed. Couples therapy should also be included, since the entire episode of bulimia nervosa was triggered by the critical comments made by the spouse of the patient. The spouse could be incorporated into some treatment sessions at some point, or they could engage in some other type of couples or family therapy. The cognitive behavioral therapy treatments could be administered either in a clinic setting or in some type of telemedicine internet-based format, as studies have shown that both formats are effective. Pharmacotherapy with the SSRI fluoxetine should be part of the treatment plan, as studies have shown that it is useful in helping to reduce the inappropriate compensatory behaviors of binging and purging. This should be considered as part of the treatment plan to help the patient get these behaviors under control. In contrast to anorexia nervosa, for some individuals with bulimia nervosa, pharmacotherapy alone with the use of the SSRI fluoxetine has proven to be an effective standalone treatment. Another possible beneficial treatment to consider, which would need to be discussed with the patient first, would be a day hospital treatment setting in which the patient would be treated with a brief, intense cognitive behavioral therapy rapid response intervention early on in the treatment process for at least 4 weeks. And this would be done in addition to the treatments and therapy that is provided in a traditional day hospital treatment setting. The reason for this recommendation is because many studies have shown that patients suffering from bulimia nervosa have shown that early symptom changes in the treatment process is a good predictor of better long-term patient outcomes. The patient is actually an ideal candidate for this type of treatment because he has not received any other treatment prior for his eating disorder. The results of this type of intervention showed that the individuals that received the cognitive behavioral therapy rapid response had a higher rapid response with a p-value of 0.04. They also displayed less binge-purge episodes with a p-value of 0.02. And with evaluation at the end of treatment, it was also shown that the participants had a p-value of 0.008 regarding evaluation of weight and shape. As part of the treatment plan, a referral to a dentist would be necessary as frequent vomiting can permanently wear down the enamel of teeth while also contributing to poor oral health. A referral to a nutritionist would also be a good part of the treatment plan so that this patient can learn healthy eating habits and help to build a healthy relationship with food. Here are a list of the references that were used throughout the presentation, and I thank you so much for your time and for viewing the presentation. Thank you.